come for the next discussion, the fifth one, and we were discussing regarding pathologies when there are stones in the gallbladder. So, last three presentations we discussed how stones in the gallbladder can present in three different ways: biliary colic, acute cholecystitis, or chronic cholecystitis. There's one important thing to remember though: a significant number of patients who have stones in the gallbladder may not even know because they don't have any symptoms. But of course, if a scan is done for something else, you find these stones, and this is called an incidental finding, where there are stones in the gallbladder without symptoms. Those cases we can just observe. There are some special circumstances, but I'll not discuss those. But as a general rule, you can consider that asymptomatic stones doesn't need any treatment. So look at today's clinical history. Take a minute and read it. So a person who comes, this is a fairly straightforward presentation, not a difficult one, who complains of tea color urine and yellow eyes. So you know that he has jaundice. But there are three categories of jaundice: the prehepatic, due to excessive hemolysis or hepatic problems, or the post-hepatic, the obstructive jaundice. And as a surgeon, what is important for me is obstructive jaundice. So first thing, when a person comes to me with jaundice, I'll try to rule out or confirm the possibility of obstructive jaundice. And in any case of jaundice, probably that is one easy way. So when the bile duct system is obstructed, the bile pigments doesn't get into the intestine and the stools will become pale. So you ask whether your stools are pale. And also because bile salts are getting reabsorbed, that causes, when deposited in the skin, it causes a pruritus. It's a really bothering symptom for people with obstructive jaundice. So a person comes with jaundice, and if there is pruritus and pale stools, clinically you can confirm that it is an obstructive jaundice. So what is the next task in the history? So very straightforward. You have confirmed obstructive jaundice. To find the cause for the obstructive jaundice, what is obstructing the passage of bile into the intestine? So to look at in a general manner, any hollow viscous, when it gets obstructed, there are common things that you have to consider. And in some hollow viscous, it may be not applicable, but you just apply and see. So one thing is, a common thing obstructing the duct system are stones, a stone obstructing. And the other common thing causing obstruction of a hollow viscous is a tumor in the wall of the organ. A tumor in the wall of the organ. And or else it could be a tumor compressing from outside, a tumor in a related organ, either compressing or infiltrating the particular hollow viscous. Or it may be due to fibrosis. Fibrosis causes contraction, and a hollow viscous can get obstructed by a fibrosis. Or another thing is, of course, it could be a congenital problem. Usually congenital causes of obstruction present in the early years, but there are some which may present later. So with this key of different things, take a paper and pencil or pen and write what is applicable to the biliary system to get obstructed out of these. Make a list. So pause the video for a while and make a list and see how many causes you can list down. Okay, so probably you have got this list. One thing, it could be a stone in the bile duct. It can be a stone in the bile duct, or compression from outside or infiltration from outside. see ahead of the pancreas. It can obstruct the bile duct. And then the malignancies of the biliary system. So you can have cholangiocarcinomas, and there are two special names given for them. If the tumor happens in the hilum, that's called a Klatskin tumor. That's a common site for cholangiocarcinomas. But anywhere in the bile duct, you can have cholangiocarcinomas. Another common site is at the ampulla, which is called a periampullary carcinoma. And then strictures, the fibrotic causes. You can have a stricture in the bile duct. And to have a stricture, there has to be something damaging the duct. The commonest cause for benign stricture of the bile duct is previous cholecystectomy. You operate on this organ and you can cause some damage. It may happen just at the surgery if you directly go and ligate the duct, or sometimes they present later. You has caused some ischemia there and there is a fibrosis. So both are possible. And other fibrotic cause is chronic pancreatitis. There's fibrosis of the pancreatic gland, and by that your bile duct can get sometimes narrowed down. And a congenital cause, choledochal cyst, that's a cystic dilatation of the ducts. So this also in some cases it presents as obstructive jaundice. So the importance is now with the history, how can we find what is the cause for the jaundice? And we'll take one by one. CBD stone, and most of the stones they form in the gallbladder, and they go out of the gallbladder and obstruct the duct. And for a stone to go out of the gallbladder has to contract very strongly because it has to dilate the cystic duct and push the stone out. So it's important to ask the patient before the onset of jaundice whether they had a severe upper abdominal pain, and most of the patients will give this history. So a person comes with features of obstructive jaundice, you ask whether there was a preceding before the jaundice, not at the time of jaundice, before the jaundice, whether there was a severe pain suggestive of biliary colic. If they say yes, it's you have a fair certainty that the problem is a CBD stone. Then the malignancies. The malignancies, you will have a progressive jaundice over maybe, it depends on when the patient present, maybe a couple of weeks, or sometimes it may be 1 month or even more. But it's a progressively increasing jaundice. And also they can have other cachectic features like loss of appetite, loss of weight. So those things will be there. And with the periampullary carcinoma, because the growth is at where it opens to the duct, so the tumor can ulcerate and sometimes it can bleed. It can bleed into the duodenum, and they may even notice melena, or some people may have features of anemia when you examine. And also theoretically, there's a possibility that when tumor ulcerate, there may be some escape of bile. So there may be a minor fluctuation which patient may not notice sometimes, but of course it may be there. And with malignancies, do you get pain? Well, at the beginning, no, there won't be any pain before the onset of jaundice or the beginning part of the jaundice. But say like a head of pancreas especially, if it gets advanced, it infiltrates into the nerve plexus, then the person will have pain, and it will be a persistent pain. And then it's different to the CBD stone story. There you have a preceding severe pain suggestive of colic and then jaundice. Here you have progressive jaundice and untreated for some time. They develop infiltration, they can have a persistent pain. And stricture, as I said, the commonest cause for stricture is previous cholecystectomy. So in the past surgical history, it's mandatory that you have to ask whether you underwent cholecystectomy in the past. If it is yes, then you have to be very suspicious that whether it's a stricture. And then chronic pancreatitis. And chronic pancreatitis will have a typical pancreatic pain. So before the onset of jaundice, they will have pain suggestive of pancreatitis. They have epigastric pain radiating to the back, bending forward relief. And there may be other features of chronic pancreatitis like polyuria, polydipsia, or maybe diagnosed diabetic, and also may have steatorrhea, and the history, the person may be alcoholic. So you have features of chronic pancreatitis there. And then now person is developing jaundice. Cholesteral cyst, generally it happens in a bit of a young age, and of course sometimes with the history it's difficult to definitely say it's a cholesteral cyst, but there may be a bit of a fluctuating jaundice here also, and it may suggest. So now the person I presented had this typical history of a severe colic before the jaundice. So when we took the history, he had a severe colic before the jaundice, and he didn't have any cachectic features, and there was no history of pancreatitis. And also, of course, then you have to do your systemic review the other systems, and then examination. So what are the physical signs important to look for? Now this history is suggestive of stone, but of course you never know, it may be something else. So in the examination you will be careful to look for all the possible physical signs which may be when they are in the other things. So of course you first have to see whether the patient is jaundice, and you may see the scratch marks of pruritus, and look for lymph nodes, especially the left supraclavicular, because if the lymph node is there, you are going to change your diagnosis, which you thought is a stone. And cardiovascular respiratory examination is important. Abdomen, and see whether there's any distension and whether there's any tend area. So with this type of one, this patient didn't have any. The abdomen was a soft and non-tender abdomen. And there is one very physical, important physical sign. Now our clinical suspicion is whether it's a stone, CBD stone, and that is whether the gallbladder is palpable. So this is a very important thing in a case of obstructive jaundice, to come to a conclusion of of a clinical diagnosis. Now look at this. When there's a CBD stone, your bile duct system will dilate, all your extrahepatic will dilate, and also the intrahepatic will dilate. And the origin of the stone is the gallbladder. And usually when there are stones in the gallbladder and it have been contracting hard to expel the stones, usually this gallbladder gets chronically inflamed, a fibrotic gallbladder, which so therefore it doesn't distend. Even though all your back system has distended, the gallbladder won't distend. So when you examine, you can't feel a distended gallbladder. So in this patient, he came with obstructive jaundice, had a history of colic suggestive stone, and examination of the abdomen. The gallbladder was not palpable. It is not palpable, and it is in favor of a clinical diagnosis of a CBD stone. So now what are we going to do? We have to confirm by imaging. So here we did a ultrasound scan which confirmed the diagnosis. It showed that there are stones in the gallbladder, and also that there are common bile duct stones. So with a definite history and examination findings and scan, we have confirmed the diagnosis. And a CT scan will show other, it may double confirm, but it is, if you are 100% sure, it may be not essential. But in an elderly person, of course you may do it, but generally with everything suggestive, ultrasound will make the diagnosis for you. So but of course there are other investigations for the hepatobiliary system in obstructive, or CT scan, also MRCP is available, endoscopic ultrasound is there. All are good tools, but of course you have to be rational in picking up investigations. Otherwise you'll be wasting resources, and it will also, if you unnecessarily investigate, that's another bad thing, that there will be a lot of waiting list being created. So we took the diagnosis as a CBD stone causing the obstructive jaundice by the history of a biliary colic, and then getting the jaundice and gallbladder being not palpable, and ultrasound scan has now confirmed. So how are we going to treat? So just look at this and how to treat. I'm sure it will open up in your mind, because there is a stone in the bile duct and there are stones in the gallbladder. So those have to be removed. So if you are asked in the past, before minimal access therapy came in, what surgeons did was they did a laparotomy and removed the CBD stone, and at the same time they removed the gallbladder. Perfectly okay, the patient will get better. So cholecystectomy and what is called exploration of the bile duct. But now with minimal access therapy coming in, things have changed a bit. But anyway, there are two concepts here for the treatment. One thing is that you have to remove the CBD duct stone has to be removed, and also the gallbladder has to be removed. So these are the two principles. And one way in the past people were doing was doing both together with a cholecystectomy and expression of the bile duct. But how did we treat this patient? We took the patient to the endoscopy for a ERCP. So with the ERCP, you have an endoscopy to come to the ampulla. And this is a special type of endoscope which is called a side viewing endoscopy. With a normal end viewing, it's difficult to look at the papilla, the ampulla, because it is on the side. So you have a special endoscope called the side viewing. So you come there with the side viewing endoscope, and then you cannulate the bile duct, and you can inject contrast and have a look. So therefore you should have a C-arm. You should have a C-arm, and once you come here, you inject the contrast, and with the C-arm you get the radiographic image there. And I'll just show a small video clip where when the papilla is seen what is being done. So first it will be what is called cannulated, and then you can inject diluted contrast and get an image and confirm that there are stones. And with ERCP you can remove the stone, and to remove the stone, generally the sphincter, it has to be opened out. So we do what is called a sphincterotomy. We divide the sphincter of body to make it wider. So look at this. So you can see the that's a papilla and the ampulla of water, and then it is now being cannulated. And now what you're going to see is the what is called the sphincterotomy, and this blade is open. With diathermy we do the cutting. It's not so it's a diathermy cutting. So that's now we have done the sphincterotomy, and this of course in the third stage. I combine many clips here. This is actually passing a stent into the bile duct. So after removal stones, you may pass a stent, but if you're 100% sure all stones have come out, it may be not absolutely necessary. So this is passing a stent. So the steps will be: you come into the papilla, cannulate, inject contrast, get an image and confirm your stones. And to remove, you have to do a sphincterotomy. And how can you remove the stones? One thing is you can pass a what is called a balloon, and this in the balloon and pull the stones, which is called balloon extraction. And in this patient, it was done with using a Domia basket. And so this is the image of. So this is your endoscope at the ampulla, and you cannulated, inject the contrast, and you can see actually he had multiple stones in the bile duct, and then they were removed by using a Domia basket, and you can see the Domia basket and stone. So his duct was cleared of the stones, and then subsequently he underwent laparoscopic cholecystectomy. So here it's a two-stage procedure. First you do the ERCP and removal of the stone, and then you do the laparoscopic cholecystectomy. The advantage is both are minimal access techniques, so you don't make a laparotomy on this patient. In the past, it was laparotomy and cholecystectomy and expansion of the bile duct together. But of course, the patient will get better in one go, so there's an advantage there also. But here, two-stage, this mostly in our country is done like in this manner: do a ERCP, remove the stone, and then do the cholecystectomy. So he underwent the laparoscopic cholecystectomy, and of course you can see that the gallbladder is getting pulled through one of the ports. So there's no big laparotomy on him. So he got better. So to summarize, a person coming with a CBD stone, his presentation was with obstructive jaundice, and to find the diagnosis, the history of the biliary colic before the jaundice clinically suggested that is a CBD stone. An examination using trach, he didn't have any features suggestive of malignancy, and the gallbladder was not palpable, which is typically seen when a stone in the bile duct obstructs. And the ultrasound scan confirmed, and he was managed with a ERCP, removal of the stone, and then cholecystectomy. A few things that you have to work out. One thing is, now I said he underwent ERCP and then the cholecystectomy. And what is the gap in between? So you do say, suppose you do the ERCP today and you are remove the stone. When are you going to book him for the cholecystectomy? So find this from your ward patients and also by the notes. Of course, you can read a textbook, and I have given some handouts on these things. So from somewhere you find, but it's always better to learn from your patients. You will not remember. You will not, sorry, forget it. And then another question, there are instances where ERCP will fail. Sometimes you fail to cannulate, or sometimes the stone is big and you can just extract it. So in that case, what are you going to do? If ERCP fail, what is your management? And also, of course, in my previous discussion, the clue was given to you. And then, what is a T-tube? What is a T-tube, and why do you use a T-tube? Why should you insert what is called this T-tube, and how do you manage if you insert a T-tube? So these also you can read in your textbooks, and also the notes I have given. And also, if a person undergoes this type of surgery and T-tube insert, learn from the patient. You will never forget. Thank you.